Welcome to the California Immunization Coalition Education Hour. My name is Cameron, and today's Education Hour will be about the California Immunization Registry update.
Thank you so much, Cameron. Hello, everyone, and welcome. I'm Meg Dorsey, a public health nurse in Placer County, also a CIC board member and chairperson for the CIC Education Committee, and I'll be your host and your moderator for today's call. The California Immunization Coalition hosts education hours throughout the year on immunization-related topics to help our colleagues stay updated and informed about important news and information. Many public servants at the California Immunization Branch have had to drop things and/or do double duty during this time of pandemic. But lots of important work has been going on at the branch to strengthen CAIR 2, our California Immunization Registry, which has become an invaluable resource. For example, once COVID-19 vaccines became available, the registry has been an indispensable tool for recording and reporting data to help determine how we are doing and how we can best focus and strengthen our efforts in vaccination outreach. This is vital in assisting healthcare providers, health departments, schools, and others who work to protect our communities with vaccinations. Our speaker today, I'm so delighted to welcome Michael Powell. Michael is the chief of the Registry and Assessment Section at the California Department of Public Health Immunization Branch, and he will be providing an update for us on new developments and goals in the future of CAIR 2. Michael joined the Immunization Branch in 2010 and has worked in information technology and IT management for 25 years. Michael speaks frequently throughout the state about the registry and interfaces with many organizations from other states. He's educating, empowering many immunization stakeholders. We hope that this program will be especially useful for the 34,000 registry users throughout the state, and also encourage others to jump in and take that very important step of including their patient data to strengthen this important resource. We anticipate many questions today, so feel free to submit your questions at any time during the program via the question box, and you can find that little logo at the bottom right corner of your screen. We will address all questions at the end of the program. If you are having technical difficulties, please put your concern in the chat box and we will attempt to assist you promptly. Also, following today's webinar, as always, a recording of the webinar will be available on the CIC YouTube channel, which you can access via immunizeca.org website. If you're unfamiliar with this feature on the CIC website, please take a look at it. There are many excellent archive programs there for you to take a look at. So Michael, we are ready to begin the presentation, and I'm going to turn the mic over to you. And thanks again for being here.
Thank you, Meg. Greatly appreciated, and thank you for having me. I am going to turn my video off while I present just to save bandwidth, but I will let you guys see me again during Q&A. Next slide, please. Next slide. I want to talk a little bit today about the historical background of CAIR for those of you who may not be familiar, where we are today, especially in the world of COVID, and the things that we have done to prepare for the future and future pandemics, which we hope doesn't happen, but inevitably may. And a little bit about the digital COVID vaccine record, which is something that we deployed during COVID the middle of last year. Next slide, please. In the late 80s, early 90s, there was a measles outbreak in the United States. And this is important because it led to the development of many new programs in California and the US in general, but California in particular, being the largest state, we had the most impact, not only from the outbreak itself, but from the response to the outbreak. Next slide. The two significant developments that came out of the measles outbreak was the Vaccines for Children program, which I'm sure you're all familiar with, and then the computerization of immunization record keeping. This was making all immunization records electronic, or doing our best to make them all electronic. Next slide, please. During this time, All Kids Count, which is the Robert Wood Johnson Foundation, developed an immunization monitoring and follow-up systems as a strategy to improve coverage rates within California or within the US, but in particular California. There are 38 grantees, 17 were state local health departments, and 21 were local health departments in California. Next slide. Of the 38 projects to build the immunization registry, 7 were California counties, and they're listed here. But if you notice in the list, they have different timeframes for which the foundation funded these projects. And this is really important as we started developing an immunization registry that fit California appropriately as opposed to being segregated. Next slide, please. So early in this transition or in this phase in the 1990s, each county had their own immunization registry, but these counties did not talk to each other. So if you got immunized in San Diego and then moved to San Francisco, the healthcare providers in San Francisco could not see your previous immunization history. What this led to a lot of times was over-immunization or people not wanting to go to the doctor because they didn't want to get immunized again. And this led to what we call the 10 regions in California, where the immunization registries became regionalized. There were two distinct reasons for this regionalization. One was we wanted to try to get the counties to communicate with each other so that if you did move between counties that were close to each other, you would still be able to have, or your providers would have access to your immunization records. The other reason, quite frankly, was as funding dried up from the foundation, counties started working together to build common systems. And this is really important to the future of the registry or data systems in general, is having that common system. So in the 10 region model, which was in the early 2000s, the funding for those regions also started to dry up, and we had to start taking in the regions within the state. So in 2010, we had 10 regions, but 7 of those 10 regions were on identical platforms, but they still didn't talk to each other. They were using the same software, the same server systems, but they couldn't talk to each other. This is when we started developing the theory or the strategy for CAIR 2. And the goal behind CAIR 2 was to consolidate those 7 of the 10 regions that we managed at the state level into one immunization registry, and then to build a data sharing model with the 3 independent registries. And the 3 independent registries being San Diego, often referred to as SDIR, Imperial County, and the counties around San Joaquin, the Healthy Futures counties, which we call RIDE. Unfortunately, you can go to the next slide, please. Unfortunately, those plans were stalled due to COVID, but before COVID hit, we did migrate Imperial County into CAIR 2, leaving us with 3 regions. So the 3 regions that are left were San Diego, CAIR 2, and RIDE. And then last year, we started working, you can go to the next slide, please. We started working with San Diego. Oh, I'm sorry. I thought there was a transition on the last slide. If you could go back, go forward one. We started working on a transition with San Diego, and we are on target to have them migrated into CAIR 2 next month in April of this year. So then we'll have 2 registries. We'll have RIDE, the 8 counties around San Joaquin, and CAIR 2. And we will still implement a data sharing strategy with Healthy Futures so that anyone in California or any provider in California can get a full vision of a patient regardless of where they were immunized within the state. Next slide. A little bit about the statute that covers registry use. This is also very important. The Health and Safety Code 120440 governs registry use, who is allowed to use it, for what purposes it can be used. And this really models everything that we do at the registry. Now keep in mind, outside of COVID, the registry is voluntary, and it is an all-age registry. It's not just for school children. It's not, and so we do have adults. It's a birth to death registry for immunizations. However, with COVID, since COVID reporting is mandatory, that has changed our values a little bit, and I'll get to that a little bit later, for the positive, and has also made us realize how important, or I shouldn't say made us, we probably all realize how important the registry is on this call, but it made others realize how important the registry is outside of those who deal with the registry on a day-to-day basis. The authorized users for the registry are listed below. Healthcare providers, schools. Schools have different levels of access depending on what their function is. Childcare facilities, local health departments, women and infant children's program, healthcare plans who have access through the HEDIS process, which is it's a data quality measure that health plans use to see if their providers are vaccinating their patients properly, at the right intervals and everything. Foster care agencies and county welfare departments may also have access to the registry under, as long as they have the authorized use. Next slide, please. Part of the disclosure, or part of the health and safety code, is how our disclosure is defined. And the way that disclosure is defined in the registry is a patient has to be notified that their data is going to the registry. And the slide is our standard disclosure language. This is not an opt-out registry, but the registry is, you have to be notified by your provider that we're going to immunize you and we are going to send your data to the registry. But you do have the right to lock your record. And what that means is, when you lock your record, that only the person who provided you the immunization and public health can see your record unless you consent to otherwise. And we have forms online that allow you to make this request to either lock or unlock your record depending on the circumstances. But I want to be really clear that that's a misconception by a lot of people about the registry, that it's an opt-in registry. It's not. It is not an opt-in registry. It's not an opt-out registry. If your data is being sent to the registry, you just have to be disclosed that your data is being sent to the registry. Next slide, please. There's some standard immunization, IIS is immunization information systems. For any geeks in the audience, I know IIS has different meanings, but in this circumstance, it's immunization information systems. The features of the IIS is to consolidate immunizations from different sources. So if you get a dose at CAIR and then you get a dose at Rite Aid, they should all land in one place so that someone can see, your provider or a doctor that you go visit can see your full record. The registry also helps assist in determining what immunizations are due. We have a very sophisticated vaccine scheduler that follows the ACIP model, or the ACIP recommendations, and will notify you when patients are due. And there's a pretty sophisticated reminder recall system within the registry as well to help you manage getting those people in to get them vaccinated. The CAIR, or the registry, also has inventory features for those who want to manage their inventory through the registry. We have a pretty sophisticated inventory module to help with that. And we also have a lot of aggregate and patient-specific reporting modules that are built into the registry. And in addition to that, there's also some ad hoc features where if you need to customize your reports, there's ability for that for certain user levels to do ad hoc reports out of the registry as well. Next slide, please. If you want to participate in the registry, we have all of our forms are online now. We have online enrollment. We have online training. You can sign up for training online. You can add and remove users online. This all used to be done by paper, but we have made everything electronic now. And we also have plans to further modernize our systems so that they integrate better with different systems, including the Vaccines for Children program, which I'll talk about a little bit later. And we also have a wide variety of videos and user guides online training videos online that you can view. For our read-only users, this is an invaluable resource because all of their training is done through these videos. Next slide, please. So what does the registry look like? This is as of January. These numbers have gone up a little bit since then, but Currently, we have almost 45 million patients in CAIR 2. This is CAIR 2 only. This does not include San Diego and does not include Healthy Futures. And we have over 400 million doses in the registry. This is really good for California. This means that with the advent of COVID and people getting more in a routine of submitting doses to the registry, those values have gone up a lot. This is really, really important as we look at the future of the registry and how it can benefit other systems. Next slide, please. We also have bidirectional sites. And what a bidirectional site is a site that not only sends data to the registry, but also gets data out of the registry electronically. And currently, right now, we have about 1,600 VFC sites that do data exchange, and 42% of those sites are doing bidirectional data exchange. This is important as well because it allows the provider to know what other sites have other sites have immunized a patient against so that they're not over immunizing patients like we talked about earlier in the presentation. Next slide, please. I'm going to go through a couple of slides with numbers. So in the next few, just an overview of our section. This is what our section looks like today. I'm not going to go through all of the nitty gritty, but the important takeaway is that we have a large technical team that does a lot of our software development and quality assurance in-house. We have a large data exchange team that works directly with providers on getting onboarded for electronic data exchange. That includes both the vaccine, just sending us the vaccines, and also the bidirectional exchange, which I just spoke about. And then we have a help desk that we manage to assist users with account update, with account enrollment, and also technical issues with the registry itself. Then we also have an indirect reporting line to our field services staff, which are listed on the right. And these are the people who do our provider support and outreach in the field. And we work very closely with them to make sure that we're giving the providers the best possible service we can. Next slide, please. So this is our vaccines for children participation, and this is an area that we would like to improve. And part of that improvement is going to be in integrating the two systems eventually together, which I'll talk more about the integration in our future plans. But right now, we only have about 73% of the people who are registered as VFC providers in CAIR 2 that are linked to the VFC program. We really like to get that number to 100%. This is just informational. This is something that we're already working on, but it's the one takeaway from this is that even though it's only 73% and we'd like to get that up higher, this is still showing improvement from years past, that we are improving this year by year. Next slide, please. We have many different types of user roles in CAIR 2 that you can use. We have added some roles like our data exchange quality assurance role. And the reason we've added these roles is to give people an option to be able to log into the interface of CAIR 2 to look at the data that's coming in. One of the patterns we noticed was data exchange providers were submitting data, but nobody was checking that data. So there was no quality assurance on that data. We were just getting it and it may have been right and there may have been issues. With this quality assurance role that we added, it allows people to go in and look at their data and go, oh, we should have had 10,000 doses come in yesterday and we're only showing 8. What happened to the other 2,000 doses? Or they submitted the wrong dose. We've had a couple where they submitted large batches of people getting a hepatitis B vaccination when it should have been hepatitis A. So that's helped us improve our data quality. And we have also have some very specific roles for the county level, for the county public health departments, where they can run reports for their entire county. And this is something that's going to, be something that's we're going to improve on in the future of the registry as well. Next slide, please. So this is our data sharing model, and I left this slide in just because I wanted to talk a little bit about how we were going to do the transition. I should have put a cross through the San Diego one since we're not going to be doing nightly updates since they're fully integrating into CAIR 2. But the takeaway from this for San Joaquin for Healthy Futures is anything that CAIR 2, if anybody logs into CAIR 2 and does a query for a person, and we can't find the person in CAIR 2, or even if we can, we will run a query. I'm sorry, if this is starting in Healthy Futures. If they look up a patient in Healthy Futures, they can't find the patient right away. Or if they want to manually look up that same patient in CAIR 2, they can right from their software. And then the other way is the Healthy Futures system will send us regular updates so we consume the data in CAIR 2. So all of the Healthy Futures data will be in our database as well. So if you are in one of the CAIR 2 regions and are looking up data in CAIR 2, you will be able to see all patients regardless of their residency in California. Next slide. This is also an important statistic. Meg mentioned earlier, we have 34,000 users. Those are the manual entry users. That represents 14% of the data that's coming in. The other 86% of the data that comes into the registry is through provider electronic health records. That's the electronic data exchange. When I started in 2010, this number was 9% EHRs, 91% manual entry. And with manual entry, it's directly proportionate to how your data quality is affected. The more manual entry you have, the more data entry errors you'll have. So this is a great improvement as well as we move towards the higher percentage of EHR submitting data. It's also improving our data quality. Next slide. This is just a graph showing the activity of people participating in bidirectional data exchange over time, starting in August of 2017, which is about when we finished our implementation of CAIR 2, until February of this year. And as you can tell, even with COVID, we saw our providers not going up quite as high in areas, but the number of queries clearly went higher. We are roughly about 4 million a month now queries for queries and for vaccines that are coming in combined. That's a huge workload on our system. But again, this is all very valuable. As the more data points we have, the better our data is going to be in the future. Next point, or next slide. Admittedly, we do have some data issues in CAIR 2. The biggest right now that we're trying to tackle is duplicate patients. And we have a pretty sophisticated process that matches patients that are already in the system, but it's not perfect. Right now, we have over 400,000 suspected duplicate patients in the registry. This represents about 1% of the registry, but 400,000 is quite a large number. And we're working on automated solutions, which is what RPA is. We're working on automated solutions to help merge the requests and also to split out the ones that really do need human eyes to look at. Because before this automated process, we had humans doing this work, and it's almost insurmountable to catch up on. With that, improved matching algorithm, an improved matching algorithm is also being researched, and we are looking at things like master patient index, things to improve the matching from that perspective, as well as proven solutions that other systems are using to match records, like in the financial industry or other industries that we may be able to leverage. One of the other issues that we had when we migrated data from CAIR 1 to CAIR 2, all data from CAIR 1 came over as active patients for all organizations in CAIR 2. We did implement a module called Manage Patient Status, which allows providers to either activate or inactivate patients in a bulk fashion. The way that it works, or used to work, is you had to go into a patient one by one and mark their status as inactive if they were no longer with your practice. Now you can go through, you have a checklist, and you can select 10 or 100 people at a time and inactivate them or activate them. And that's really helped as well. This was implemented early last year and has gotten a lot of use so far, and that's really improved a lot of our patient records. We also have issues of people sending the incorrect vaccines, which I talked a little bit about earlier. We have ways to go back and correct those, but the problem is isolating those and finding the ones that are incorrect in order to correct, and that we often have to rely on provider sites to notify us when they've made a mistake. We're working on implementing tools to correct that as well. And then we also have a lot of sites, particularly VFC sites, that are not sending vaccine eligibility information, which is really important that we get that information. So we have outreach teams that are working on improving that data population as well. Next slide, please. All of these forms for registering for the for data exchange, whether it be bidirectional or regular data exchange, are available online. We have a survey that allows you to complete the survey to see if you're ready for this type of interface. And if not, we have people that can work with you to do that. We have our data exchange team, which I talked a little bit about earlier, are very knowledgeable and will do interviews with you to talk about how we can best service your EHR and get you going with connection to CAIR 2. Next slide. So how does the message flow work? And I'm going to kind of fly through this because this can be a little technical, but in general, you have a terminal that you sit on at a provider office that has your electronic health record on it, and you have CAIR 2. And how does that data get there? Next slide. We have something called a VXU, which is an unsolicited vaccine update. When I talk about sending us vaccine information, we refer to that as a VXU. That's what an EHR sends to us. It has things in it like your name, your date of birth, your address, what vaccine you received, who's your next of kin, your phone number, your email address, both of which are very important these days, and I'll explain why in a minute. Race, ethnicity, demographic information, all of that gets consumed into the registry. And then when we get it, we send something back to you, an acknowledgement saying, hey, we got your message. It all looks good. You don't have to do anything. Or we may send you a message back that says, hey, you're missing these key data elements and we can't process your message. That's called a negative acknowledgement. Or it could be an informational acknowledgement saying, hey, we got your message, you're missing these fields, but we accepted your data anyway. The computer, the electronic health record, knows how to handle all these responses. So there's no human intervention needed except if it gets escalated and has to be reprogrammed for some reason, then a human has to get involved. But in general, this is all done at the computer level. Next slide, please. So bidirectional follows a similar process, but what it does is the EHR sends a message to CAIR 2 and says, hey, I have Michael Powell in my system. Do you have a Michael Powell born on this date with this demographic information? And then CAIR 2 will do a search in our database. And then if we find that person, we'll send back and say, yes, I have Michael Powell. Here's his date of birth. Here's his address. These are the vaccines he has, and these are the vaccines he needs. And then your EHR will consume that information, depending on their business rules on how it gets consumed, will consume that information and process it appropriately for their system. So in a nutshell, that's how bidirectional works. It's all at the computer level. There's really no human intervention once it's initially set up. Next slide, please. Some things that we've done to improve both our VXUs and our queries, which we just talked about, is we implemented something called Smarty Streets. And Smarty Streets is address validation. And what address validation does, again, in a nutshell, it says, is this a legitimate address? And if it's not, it'll find something close and say, is this the address you mean? You know, or if it's a one-to-one match, it will just update the address. Like if you have 123 Main Street and street is misspelled, it'll correct Main Street. But one thing I want to be really clear about is this is not address verification. This does not say, does Michael Powell really live at this address? It just says, is this a real address? And if it's not a real address, it'll find, you know, it has logic to find the address. We've also added geocoding into CAIR 2. And this is important, not from a human interface level. This is important when we look at things like vaccine equity and what areas are there for improvement, who's getting vaccinated where, and why not? Why aren't they getting vaccinated in certain areas? Now that we have geocoding built into the system, we can use that in our analysis to really drill down even beyond the zip code level in some manner to find out where our areas of focus should be or where are we overlooking. We've also improved our county to zip crosswalks, and for zip codes, we had an issue in California because there are zip codes that cross county lines, that cross cities, or cities. Well, obviously cities have multiple zip codes, but we also have zip codes that cover multiple cities. And in our in the infancy or the early days of the registry, we didn't handle that very well. So we've done a lot of work to improve that. And we've also done a lot of work to improve how our providers populate race and ethnicity. Now, this isn't necessarily a data problem within the registry. We've always been able to handle race and ethnicity, but we had a problem getting people to provide it to us. So we put together some outreach teams and education around why is it important to include race and ethnicity. And that's really improved our race and ethnicity rates, particularly with COVID and how we're looking at COVID data and analyzing that for future reference for how we're going to handle, again, hopefully we don't have to worry about it, but future pandemics. Next slide, please. Another upgrade that we're working on is the CAIR Resource Center. We're working on improving our online features, our onboarding. This is what I was talking about, the modernization of our user training, account update, account enrollment. All of these things are being worked on now to improve not just the interface and the ease for the user entering information, but on the back end of having the different systems talk to each other, which a lot of them don't talk to each other right now. We're also working on monitoring tools for data quality that are not human. We're working on digital software solutions that will help us with data quality and monitoring in general. And then I highlighted the last one because this is saying a coming upgrade, but we actually rolled out our iQuip module last week. It hasn't been announced yet to everyone, as we're still looking at to make sure that everything is working properly, but we are ready to announce it very shortly for the clinics to use. This is particularly important to the VFC program because it allows you, this is the future of COCASA for anyone who's familiar with COCASA reports. And so far it's testing quite well. Next slide. And this is where I was talking about the improved VFC and CAIR2 data integration, because we want to be able to share inventory information with the two different systems. One of the other things that we're working on is single sign-on. And the reason that we're really focusing on single sign-on is for security. We really like the idea that a user is responsible for their own security in a sense. So they're responsible for their password. They're responsible for maintaining their password. If they forget their password, they're responsible for resetting that password. It's all done through an identity management system. Think about it like your Google account or your Microsoft account. Many of you probably have Microsoft accounts or even CAIR. CAIR has a identity management system, which I believe uses Microsoft Azure. This allows you to have a single place to manage your username and your password. So if you have a CAIR account and it's associated with single sign-on for CAIR2, all you have to do is log into CAIR. And then if you're authorized for CAIR2, you would automatically have access to CAIR2. If you forget your password, you don't come to CAIR2 to reset your password. You go to whoever is managing your account, and a lot of times that's you, to reset your password. So you click on forgot password, you go through the process of knowing what color your first car was and hope you spell it right and all of that stuff, and you can reset your password. This is going to be common for all CDPH systems in the future because it is part of our security requirements for pretty much from this day forward. We're also looking at being able to do automated exports of doses administered and doses in inventory from CAIR2 to VFC ordering. So when you go to VFC and you want to order something, you can import your data from CAIR2 instead of having to either run the report, look it up, or hope you have it written down on paper, or guessing, which I'm assuming some people do in some cases, and to get that order into the system. And vice versa. We also want to be able to take that inventory data from VFC and import it into CAIR2 in certain circumstances where it's needed. Next slide, please. So this is what the VFC, my VFC vaccines to CAIR 2 data linkage would look like. I'm not going to go through every single one of these because I think it's fairly self-explanatory, but what we really want to do at the most basic level is we want to make sure that patient doses can be accounted for in my VFC vaccines and vaccine orders can be accounted for in CAIR 2. This way, the systems will be synchronized with each other based on your CAIR organization ID and your VFC PIN if you're participating in the VFC program. Next slide, please. So the resource center will be available to the CAIR 2 system and the user. And then next slide. And then with the single sign-on, it gives you access to all these features in one login. So you would have one place to log in, one site, one landing page. And then when you log in, whatever systems you have access to, you'll be able to choose from that landing page. Next slide, please. So this is the digital COVID vaccine record. I wanted to touch a little bit on this. Last June, we rolled out my vaccine record.cdph.ca.gov. And this is our first step in consumer access to retrieve your own vaccination records. And now, of course, this is for COVID only right now. And we spent about, the Department of Technology did a lot of work on this for us. They deployed it, they wrote it, they worked with the Commons Project, which are the ones who wrote the requirements for the smart health cards. And we went live in June, and it was a huge success right from the get-go. Not that it didn't have bumps in the beginning, because we had a lot of people that couldn't find their record for one reason or another. And the main reason they couldn't find their record was because either their email address or their phone number was not given to the registry or not correct in the registry. And that's why I was talking about the email address and phone number being important data elements when they're submitting data to the registry. Because one of those two pieces is absolutely needed to retrieve your digital COVID vaccine record from our state system. To date, we delivered over 14 million digital COVID vaccine records. Again, they're all built on the Smart Health Card, and that you can also download the Smart Health Card to your Apple Health, Apple Wallet, Google Pay, or the CLEAR app. So you have it on your phone if you need to go somewhere and they need to see your vaccination status. This is not a guarantee that they will accept it. It is widely accepted today, but that doesn't mean everybody accepts it. And just to be really clear, this is not a vaccine passport. A lot of people like to call it that. That's not what this is. This is just simply a way for you to be able to retrieve your digital COVID vaccine record, have it on your phone so you don't have to carry your card, or if you are like me and can't find your card half the time, it's much easier to have it on your phone. Next slide, please. Monthly, we send out a report to all the local county health departments. And this is a sample of what that report looks like. This goes out to the immunization coordinators each month and gives them an idea. It's an Excel spreadsheet and allows them to sort, and it allows you to sort on the data, find out how many people in your county are using the registry, how they're submitting data, who's not submitting data, things of that nature. This is just a sample of what that report looks like. And I think the next page is another sample of the same report. So you can move on to the next page. Oh, I did take the second one out. So with that, I know there are a lot of questions in Q&A, Meg, so I'm not sure how you want to proceed, but I'll let you finish moderating, I guess.
Sure. Wow. Okay, well, thank you so much, Michael, for a comprehensive and interesting update on CAIR 2. A lot of information there that I know everyone was really eager to hear. And we do indeed have a lot of questions in queue. Our audience is very experienced and they certainly aren't shy in speaking up. So we have quite a few questions. I've condensed a few of them, and some of the questions were addressed in the body of the program. So let's go ahead and get started. Oh, actually, quick, just if you have been waiting to do a question and you haven't had a chance to type it in, please go ahead and type it into the Q&A section. And before we jump in on questions, I do have a little routine thing I want to just share with you. I want to remind everyone that at the end of the program, an automatic evaluation form will pop up on your screen as always. We really appreciate your responses. The CIC produces 3 to 4 of these ed hours every year, and we really rely on and value your feedback for choosing the topics and also improving the content of our calls. So just be on guard or on lookout for your evaluation form that will pop up. And Michael, here is our first question. How would you advise on responding to parents' concerns about security with the immunization registry? And do parents need to give their consent in order for others to access an immunization record, like a provider or a school?
I will address the second question first. So a parent, it depends on if the record is locked or not. If a record is not locked, then anyone who is authorized to access the registry can see that patient's data, regardless of if it's a child or if it's an adult. If the record is locked, then the parent has to give consent unless it's the patient's provider or public health. Public health can see all records. Okay. Regarding security, if you have specific security questions, you can direct them to CDPH and we'll answer those. Security is one of those subjects that's really, really hard to answer broadly. I can tell you that we follow the health for access. We follow the Health and Safety Code 120440. For our systems themselves, we have very strict architectural security standards that we have to meet for the security office. A lot of that can't be made public, but we do follow all security standards set forth by the state.
Great, thank you. Okay, do you work with other statewide registry information systems? And if so, how? And do you see a time where states will be able to talk to each other with respect to immunization records?
That is an awesome question. I'm really glad you asked that. We do work with other states from the perspective that we look at lessons learned. We talk about how we are doing things in our state. California is often looked to because our volume is so big. And they want to know, how do we handle certain things within the state? Like last spring, right at the beginning of the COVID vaccination rush, we were getting hammered with messages, and the entire country was. And they all looked to us to say, well, you're doing 6 million messages a week. How are you doing this? So we're looked to a lot in that capacity, and we're always willing to help out and have that conversation with other states. Data sharing with other states is a very different story. Because of our health and safety code, we are not allowed to share data outside of the state. That's something that is constantly talked about. We actually had a breakthrough last month with the Veterans Health Administration, where we're actually going to get data from a federal agency, but we can't get data back out. And that's the first time that we've had any kind of collaboration like that outside the state. And just in case there's any lawyers on the call, we did go through legal. It's all good. But that was a big win for us.
Great. All right. So this isn't my question, but I love this question. And here's why. I've been working in immunization since the late 80s, early 90s. And I used to think, I'm ashamed to admit this, but I used to think I and all my grandkids will be dead before we have a functional registry in this state. Because it was so hard in the beginning. Are we doing top down or bottom up? What are we doing? So I'm just completely amazed and grateful for the progress that has been made. And I remember the first time I sat down at CAIR to look up a record, and it was there, because I looked up records in the past and they weren't there. So here's the question. What are the chances of finding a needed immunization record in the registry, i.e. what's the level of population? How well populated are we?
So I mentioned on one of my slides earlier, we have about 45 million patients in the record or in the registry. So it's fairly well populated, but the vaccines themselves, from a demographic perspective, it's well populated, especially with COVID, now that everybody's getting COVID vaccinations. And what we've learned is, like Kaiser, for example, if I went to Kaiser and got a vaccine, they're sending a COVID vaccine, they're sending the COVID vaccine to the registry. But Kaiser does a great thing. They send us all the vaccines for that patient. So because the COVID vaccination was mandated, we ended up getting a lot of vaccinations we weren't getting before.
Mhm.
So it's better populated today than it was 2 years ago. 2 years ago, we had about 250 million patients or 250 million doses in the registry. So in 2 years, we've gained 150 million doses, which is huge. I couldn't put a percentage on it because even when we do our estimates with the CDC, nobody can actually tell us what the real population of California is. I think it seems to be an ever moving goalpost. But I can tell you that the chances are pretty high now of finding a patient in the registry.
That's good to hear and very encouraging.
Can I add one caveat to that? Our digital COVID vaccine record has a match rate of over 90%.
Oh my goodness.
So that's reported on weekly, but that's really good. That's really high, and I'm proud of that, or we're all proud of that. So
great. All right. Is there a way for schools to run reports to, say, do a query on their own students in the CAIR system?
There is. However, we're working on building a new school module to make it more user-friendly.
Great.
The module that's there now does work. However, it's not easy to manage. And one of the issues with the existing model is that if you have a patient if you have a student that doesn't have all their vaccines in the registry, which is pretty common, it's hard for you to get a meaningful report out of the system. The new module we're building allows a little leeway in that, where you can have a little more flexibility with your reporting, even if the data is not in the registry. I'm trying to be a little vague on that because we're still working out the details on how we're going to manage that with keeping the health and safety code into account. But we are looking at solutions for that, and we're working with a couple of experts who do school reporting in the state now to help us build that.
Wonderful. I'm sure that will be welcome news to our many school nurse partners who are listening.
I hope so too, because that's been something we've been on our mind for a long time.
Yeah, it definitely is the gold standard. And I think when you get to that point where you've built that module, I hesitate to speak for the school nurses, but I'm sure they would appreciate either a training or a video how-to on how to run those reports.
Oh, we'll definitely do something like that.
Okay. Thanks. All right, this is having to do with sensitive vaccinations. Is there an opt-out for certain shots, such as the HPV shot, which is sometimes a sensitive vaccine to have been given? And now with the legislation pending that perhaps in the future, children 12 and up will be able to consent for vaccines that they may not want their parents to know they've had. So is there a way to opt out on just a sensitive vaccine, or is the provider's only option simply not to put it in the registry?
Unfortunately, that's the only option right now. We don't have built-in functionality to hide or to have that kind of disclosure on the vaccines themselves. However, as we look at modernizing our immunization system, our immunization registry, that's something that we will be taking into account. And other states struggle with the same thing.
It's sensitive, it's difficult.
Mm-hmm.
All right, this is a good one that will be near and dear to the IZ coordinators who are listening. Is there a way for IZ coordinators to assess whether VFC providers in their jurisdiction are properly using CAIR as they should be?
Yes. That report that I showed you, that Excel spreadsheet that we send out every month, it gets posted on the IZ coordinator's website. That's your first key. You can sort that on your providers and see what their activity is, see if they're submitting data. And then if you have further questions into the registry regarding their activity, you can use your county data account, which we set up all the IZ coordinators with. If you don't have one, you can email me directly and I'll make sure that you get set up. And that'll let you run reports across your county, depending on what you need.
Okay, great. I think that's a skill that a lot of us wish we had a better skill set having to do with that particular assessment possibility. Okay, so let's see. This is another one that is near and dear to my heart. As we all are aware, pharmacies are required by law to report immunizations in California Immunization Registry. How's it going? How is pharmacy participation going? Is it monitored? Is there oversight?
Well, first of all, I have to say that it's going quite well. There is oversight because I know that we get reached out to by the pharmacy board every once in a while regarding particular submitters, and we have to do some queries for them to say, yes, they're submitting, or, this is where the gaps are. But we haven't had that very often. And our pharmacy submissions have gone through the roof since that went to effect.
Great.
So
we certainly all appreciate our pharmacy partners, in a way that we could not have envisioned 10 years ago. Okay, this question is, I'm not sure if this is a question or a comment, but it has to do with TB testing, which is a data point captured on the registry.
Mhm.
So one of our listeners says it's sometimes if there's a sequence of TB tests, it's sometimes hard to tell the date and the sequence. So is there any comment you might have on that? I'm not sure. I'm not entirely sure what that is.
No, but I would love to have that emailed to me so I can follow up on it.
Okay, I don't have the person who asked the question, but maybe shoot a question to Catherine and Cameron at the CIC, and we'll make sure we get that to Michael. Or you can send it directly to Michael.
Because we do consult with the TB program on all of our TB stuff. So I would love to have that, because that's another thing we're looking at modernizing for the future of the IS is how we can improve the TB module.
Great, wonderful. I love networking. It gets lots of good stuff done. Okay, I think you did cover this, so maybe this is just a request for some clarification. It has to do with access to records beyond the regional units that I know in the past have not coordinated with each other. But can you just clarify or reinforce the registries, the non-CAIR registries, such as Healthy Families in the San Joaquin area and the San Diego Immunization Registry? Those are all communicating at this time through CAIR.
No, not yet.
Okay, all right.
That was our plan. We actually had planned to roll that out at the beginning of last year, but COVID got in the way. So
Okay.
we halted the plans, and then for San Diego, we stopped altogether because they're migrating to CAIR 2 next month.
Okay, good. Okay.
And then after the San Diego transition, we'll reach back out to Healthy Futures and start the talks up again with them about sharing data between the two regional registries.
But the existing CAIR areas do communicate.
Oh, absolutely. Yeah, it's one area. Yeah, it's one database now.
Okay, we are one. Great.
Yeah.
All right. All right, so here's one that I've also experienced myself, and that has to do with difficulty, and I think this is probably from a school stakeholder, difficulty adding users, say a school or someone in an office that has a new staff member. If you're not a power user, it's hard to do anything and add a user. Additionally, if you're not a power user, let's just say you're a school nurse and you find errors in the record, or you have information that you'd like to enhance the record. So what would you suggest in terms of the difficulty, if you're not a power user, to add users or to correct or enhance records?
Okay, so adding users, I'll go with first. All users should be added through our account update online. Power users actually they shouldn't have rights to add users within the system. All should go through our online process. Understanding that there may be some delays in that process, we are working on improving that system as well. That's part of our modernization with integrating into the other systems. But we should not have that long of a turnaround right now, maybe a couple of days. I don't see anything sit in there for more than a couple of days. So if you do have that as an experience, please send it to send a direct communication to the help desk, and we'll get it resolved. Regarding, I'm sorry, the second part of the question again?
Well, if you're a read-only user and you want to correct something, or you want to enhance a record.
Right. So for school users specifically, if you're not running a school clinic and you're not providing immunization services, you have read-only access. And we just went through this with legal not too long ago. Because of FERPA, you do not have rights to add or change information in the registry. That has to be done by the medical provider.
Okay. All right. And then I'll make a comment following your last comment. I would say I personally have struggled to add users when I'm logged in to my account. I think there might be a mistaken understanding that you do this when you're logged into your account, as opposed to through an independent online access. I think that might be a point of information that might be helpful to share that more broadly. Because once I figured that out for myself, it was like, oh, now I get it. So it might be something that people aren't that aware of, that you don't do it once you're signed into your account. It's a different process altogether.
Yeah, there's a website, accountupdate.cairweb.org. And if you go there, that's where you log in and add users or remove users if they're no longer with the practice.
Great. I think that's good to know. And, maybe reinforce that back pocket fun fact.
So, Meg, I know we're almost out of time, but I just saw a question pop up on the Q&A that I would like to answer really quickly.
Yes.
About duplicate records.
Yes.
If you go to cairweb.org, there's an online form you can use to report duplicate records, and we'll take care of them.
Wonderful. And I guess the last quick wrap-up question for anyone, a parent or a school who needs some assistance with CAIR, what's the best way you would suggest having them contact CAIR for support?
So it really depends on what you're trying to achieve, but the two best methods are either contact our help desk directly, call them, right? If it's something that is online and technical, I would suggest calling instead of an email. Or you can reach your local CAIR representative, which depending on where you live in California, your local CAIR rep is regionalized throughout the state. And that's on cairweb.org as well. And you can find your local CAIR representative, and you can either email them or call them from the link or their information will be linked on the page. Those are the two best ways to get support. And if you find yourself in a rut that you can't get support, we'll know. But
okay.
I hate to say just email me, because I don't want everybody emailing me, because then my mailbox will get full and nobody will get responded to. But if you contacted the help desk 4 or 5 times and aren't getting help, you reach out to me and I'll see what I can do.
Thanks, Michael. That's very generous. So we're at the top of our hour. So I want to thank Michael again for his terrific update on important registry issues. And I want to thank all of you for your great questions. On behalf of the CIC Board of Directors and the Education Committee, we want to thank Michael and the whole team at the registry section for their phenomenal work before and throughout this pandemic. It's really made a difference. And a very big thanks to all of you for spending your hour here with us. Much appreciated. Please remember to complete the evaluation form that will automatically pop up. Tell us what you thought of the webinar. Check out the YouTube channel for archived programs from the past. And again, thank you so much for joining us, and enjoy the rest of your day.